Yeah. Right. It's ready.
Right. So can you see my screen now?
Yes, yes, Dr. Atul, please go ahead.
Yes. Thank you very much, Prabhat. Good afternoon, everyone. I logged in only for last 5 minutes or so, and I was listening with interest Dr. Prabhat's question, which was posed to everyone, whether this particular patient is a candidate for buprenorphine maintenance treatment or not. I really noted that question with interest, and I would be very keen to know the responses of all the esteemed participants on this issue. And perhaps after this talk, this brief session, we would be in a much better position to formulate our response whether this particular patient is suitable for buprenorphine substitution treatment or not. So let me now begin about buprenorphine substitution treatment. I will not go into too many background details because they must have been covered earlier as well. But as we all know that opioid dependence, in fact all sorts of drug dependence, are seen as chronic relapsing disorders. You know, many of our physician colleagues, they often make fun of us. They often tell us that, doctor, what's the point of you treating your patients? You treat your patients, you detoxify them, and they again come back to you with a relapse. The relapse is in fact a part and parcel of not just opioid dependence, but all other chronic non-communicable disease as well. A famous review by McClellan et al. In US had compared drug addiction, diabetes, hypertension, asthma, and found that the rates of relapse or exacerbation were almost similar in all these chronic non-communicable diseases. So in other words, opioid dependence is a condition which requires an assessment, a short-term treatment of withdrawals, which we may call as detoxification, and then followed by a long-term treatment with either agonists or antagonists. So for long-term treatment of pharmacological treatment of opioid dependence, we have two strategies: agonist maintenance and antagonist maintenance. Today we are going to focus upon agonist maintenance, and that too particularly on buprenorphine maintenance. Now, as we all know, what is known as detoxification, the old term and not so scientifically correct term, basically it entails treatment of acute withdrawal symptoms. Now, acute withdrawal symptoms last for about a few weeks only. But even after acute withdrawal phase is over, the patient continues to experience low-grade opioid withdrawal symptoms for about 4 to 6 months, what are known as protracted withdrawal syndrome or protracted abstinence. And hence, there is a very high rates of relapse if you just provide treatment of acute withdrawal symptoms, and hence it's imperative that we need a long-term treatment, long-term pharmacological treatment. So what is known as agonist substitution treatment or opioid substitution therapy, it has this particular kind of philosophy. Now, what are the kind of drugs that our patients are taking? Many of our patients are taking drugs like heroin or even injecting pharmaceuticals to take them 3 or 4 times a day. They are much more addictive, and many of them are taken by injecting route, which itself is associated with many other risk factors. So in this particular treatment, you just substitute this medically unsafe illicit compound with a medically safe agonist medication of known purity and potency, and which is legal, safer, and most importantly, long acting. Because of its long duration of action, you need to take these medicines for agonist maintenance only once a day. Hence, about 3 to 4 times a day, which you were spending earlier taking drugs, remaining under the influence of intoxication, now you save all that time and can be engaged in much more productive work. So that itself, that highlights the philosophy of agonist substitution, whereby a person's opioid need is maintained. In fact, opioids are provided to the patient to maintain his need, to satisfy his opioid need. Yet, this opioid which you are providing is much safe, longer acting, and associated with much low cost to the patients. The question would arise is, what kind of medicines would be suitable for agonist maintenance treatment approach? The medicines should have these kind of criteria. It should have a good ability to control withdrawals, should reduce the desire or craving, should have minimum side effects, should be very easy to administer, should have low dependence potential of itself. So which means it shouldn't provide too much of euphoria, too much of positive reinforcement also. It needs to be economical and easily available, and most importantly, we need it to be long acting, so that you take it just once a day, then forget about it, and for next 24 hours, you are free to engage in whatever productive work you want. Now, many medicines have been tried for this purpose, but throughout the world, methadone is the medication which is most commonly used for this purpose. In our country, however, methadone has been available only in the recent past. So only as a pilot project, we have some experience of running implementing methadone at about 4 or 5 places in the country for last 3 years or so. However, buprenorphine, we have a very long experience of using this medicine for opioid substitution treatment in our country. In fact, we can say that India was among the first countries in the world which started using buprenorphine for opioid substitution therapy. I have also written the name of opium here. You may note with interest towards the end in this list. Opium, we all know, is a fairly low potency compound, is orally active, and doesn't have too much of euphoria, because since you take it orally, it doesn't lead to very quick high and very deep intoxication either. In fact, many years back, we had a very active system of opium registry in India, whereby registered addicts were supplied opium by the government outlets. So that was a form of opioid addiction therapy, long-term maintenance therapy being provided by the government itself, only it was not called as therapy or treatment. But this practice has been discontinued, and hence we must now rely upon synthetic molecules such as buprenorphine for it. Many detractors also ask us that, boss, what's the point in giving buprenorphine to people? Why don't you just directly give them heroin? If drugs are what you are supplying to people, then why not give them heroin itself? Well, there are certain basic differences between buprenorphine and heroin. Buprenorphine is sublingual, hence there is no risk of infection. Heroin will have to be taken either by smoking or injecting route, which are not safe routes. Most importantly, buprenorphine is long acting and once a day administration would do. Heroin is a short acting, you need to take it 3 or 4 times a day. So this is how the graph would look like if someone were taking heroin. If someone would be taking heroin 3 to 4 times a day, the person would spend considerable amount of time either in the phase of intoxication or in the phase of withdrawals. And in either of these phases, intoxication or withdrawal, the person would not be totally productive. However, if you give him buprenorphine, represented by this green line, maximum amount of day would be spent neither in intoxication nor in withdrawal. Hence, the person's opioid needs will be satisfied, yet the person would be functional for most of the course of the day. And that's the most important difference we bring to lives of people who are put on agonist maintenance treatment. We make them productive again. Implementing opioid substitution
Yeah, I think there is some connection issue with Dr. Atul's net. Let's wait for 2 minutes and
Hello, can I resume again?
Yes, yes. You start from the implementation OST slide.
Okay, sure.
You can
Right? This is where all of us were?
no, you just share the screen. Your screen has gone out. You just click the share the screen, then start.
Okay. Okay. Is it okay now?
Yes, yes, can start.
Can you see my screen?
You can make full screen, sir.
It's not sharing the wrong screen. No, it's not sharing the presenter view. No, he's not a presenter.
Is it okay now?
Yes, yes, excellent.
Yeah. Right. So the first step in implementing OST is when how you recruit your patients or clients, followed by how you assess them, including their clinical history, examination, and very importantly, assessing their motivation. This is followed by a detailed session on discussion where you provide psychoeducation to your patients on what OST is all about. This is followed by obtaining their informed consent, and only even while you are implementing your treatment, you need to continuously monitor the progress of your therapy. So let's see all these steps one by one very briefly. How do you recruit your patients? First of all, if you have contacts with other service providers, if you have outreach teams in the community, they can refer patients to you, or patients can come on their own to get help for this particular kind of treatment. So what are the criteria on the basis of which we can select patients for this particular type of treatment? Various treatment guidelines have suggested various kinds of criteria. In our country, the guidelines provided by NACO or provided by the Indian Psychiatric Society also have very broad guidelines for this. So first and foremost, very importantly, the patient needs to have a diagnosis of opioid dependence, preferably with a long history. Under the National AIDS Control Program, the program is meant only for current injectors. However, when we as mental health professionals are providing this treatment, we are supposed to provide it for all kinds of opioid dependence and not just current injectors. Also, some guidelines suggest that this treatment be reserved for, or at least preferable for, those who have failed achieving abstinence through other means, namely detoxification. So patients who have been earlier admitted for detoxification and hence have a history of frequent relapses in the past are better candidates for OST. That's a view shared by many people. Also, our age more than 18 years. Many people also see this as an important criteria that you reserve this treatment, or as far as possible give this treatment only to adults who are at an age for able to give proper informed consent. And another criteria is that it should be feasible for the patient to comply with the requirements of the program. If the program requires follow-up frequently, it should be feasible for the patient to come repeatedly, see his doctor, collect his medicines, and take the medicines as prescribed by the doctor. So among these criteria for suitability, not all of them are essential. In fact, some of them are seen as essential criteria and some of them are seen as optional criteria, as we can see on this slide here. In fact, the essential criteria are only the patient needs to be a patient of opioid dependence, and secondly, patient needs to understand the implications of treatment and needs to provide the informed consent. All other criteria are largely optional. So which means even for people less than 18 years also, opioid substitution treatment with buprenorphine can be provided. The only issue in such cases is the clinician should have a clear understanding that the benefits of the treatment outweigh the likely side effects or likely adverse effects of the treatment process. For instance, there is a very young boy who comes to us with opioid dependence, but that boy has a very short history of opioid use, opioid dependence, then it means probably a course of detoxification followed by naltrexone treatment could also be suitable for him. On the other hand, if you find a teenager with, suppose, I say, antisocial traits, who has been using opioid medications with injecting route for a very long period of time, and it seems very unlikely that he will succeed with other forms of treatment. For that kind of profile, perhaps opioid substitution therapy is suitable. So the age is not sort of cast in stone. It's more about a clinician weighing the pros and cons of both the aspects of treatment. Then, when we perform the assessment, we need to generate a diagnosis of opioid dependence. We need to also determine their motivation and feasibility, whether they will be able to comply with the requirements of treatment or not. And this is followed by a very important part where we provide psychoeducation to patients about these 4 things at least. Nature of illness, all patients should understand that what they are suffering from is seen not just as a bad habit, but as a medical illness called as opioid dependence syndrome. They also need to understand that this is the treatment modality which is being prescribed to them. So, for instance, for many other conditions like depression, schizophrenia, diabetes, hypertension, you need to take long-term medicines, and hence, for this particular illness also, you need to take long-term medicines. And in fact, the duration of treatment is never pre-decided. What we know is that for any patient, at least 1 year of treatment will be required to show any discernible benefits of treatment. But beyond that, nothing can be presumed about the duration of treatment. Also, in the psychoeducation, it needs to be hammered in the patient that they need to actively participate in the treatment process. Just taking a pill every day does not ensure recovery in total. Also, taking an informed consent is always a good practice. When the opioid substitution therapy is provided as a part of a national program, such as National AIDS Control Program, then of course informed consent is necessary requirement. But even otherwise, in our clinics also, if we are providing this kind of treatment, it's always a good idea to have proper documentation, including informed consent from our patients, so that they understand what are the implications of being on this treatment. They should understand that if they miss the dose even for 1 day, they are going to experience withdrawal symptoms. And now we come to the treatment proper. The treatment with buprenorphine agonist maintenance can be divided roughly into 4 phases. The first of these phases is simply pre-induction, which means before starting this treatment. Now, what we need to understand in the phase of pre-induction is that our patients needs to be in the phase of slight acute withdrawals of opioids. Why is it important? Because buprenorphine has a very high affinity for opioid receptors. So suppose the patient which we see is under the influence of heroin. The patient has taken heroin, which means patient is currently under the influence of heroin. And now if we give him buprenorphine, we all remember, is a partial agonist, which has a high affinity. So if we give him buprenorphine will compete with heroin to occupy the opioid receptors. In fact, buprenorphine will displace heroin from the receptors, will occupy the receptors itself, and in fact will generate withdrawal symptoms. So our treatment, which we are going to give people to generate some kind of comfort, will in fact generate discomfort and withdrawal symptoms. And patients are not going to like this particular kind of effect. It's again like small children. If children are hungry, then whatever you feed them, they will like it. If they are full, then the homemade food particularly, they are not going to like it. So it's important that when you will start this treatment, the patient is in a state, which means the patient needs to abstain from short-acting opioids for 4 to 24 hours. A very good rough guide is overnight abstinence. We start our treatment for the first day only on the morning when we are sure that patient has not taken any other opioid since last night, because we want to minimize the risk of precipitated withdrawal, which are really uncomfortable for the patient. And then we start the treatment proper. Usually in our country, when we do induction, our idea is to reach the ideal daily dose of buprenorphine. And what is this ideal daily dose? Ideal daily dose is a dose how they are doing. So what the practical implication of this is, a buprenorphine treatment is not something which can be started by clinicians who have sort of weekly OPDs. Because when you start this treatment for next 3 or 4 days, you need to see your patients every day and determine the suitability of their dose. So it's always a good idea not to start this treatment when there are many weekends or public holidays are coming in next few days itself. So first day, we usually start with patients on 2 or 4 milligram of buprenorphine on first day. Our experience with Indian patients tell us that most patients would require the first dose of around 4 milligram of buprenorphine. That's the kind of habit size most of the Indian patients with opioid dependence have. Though even in India, we have a huge amount of heterogeneity as far as opioid use practices are concerned. In Northeast, people inject either pure heroin or dextropropoxyphene. In many other parts of the country, people inject either street heroin or smack, or they inject buprenorphine or pentazocine mixed with other sedatives. But even considering all these variations, a 2 to 4 milligram of first dose is usually suitable for most patients in most settings in India. After giving them the first dose of 2 or 4 milligram, it's not 2 to 4, 2 or 4. We need to monitor them for first 2 hours, which means ask them just be in the vicinity of your clinic for next 2 hours. After 2 hours, ask them once again, how are you feeling? Are they feeling any better now? If the withdrawal symptoms persist, then we can give them one more dose of 2 or 4 milligram. We just ensure that on the first day, the maximum dose of both these occasions do not exceed 8 milligram. So first dose of 2 or 4, next dose after 2 hours if required, again of 2 or 4 milligram. So first dose would be either 2 or 4 or 6 or 8. And then you send the patient back and ask them to meet you the next day. Next day when you see them, you ask them, how were the last 24 hours? And then they tell you. If they experience some craving or withdrawal between dosage, that means they were under medicated. That means your dose was not enough. The typical response by most patients is, doctor, I was fine when I was in your clinic. I was fine in fact till evening also, but by the evening I started experiencing a lot of craving and withdrawal symptoms. In fact, that night it was difficult for me to sleep. So either they would resort to either again taking their usual opioid or just bearing the withdrawal symptoms. On the contrary, if patients are over medicated, they will experience some side effects of buprenorphine. They'll experience things like, oh doctor, I was drowsy throughout the day. I just kept nodding. I couldn't walk or work properly, which means dose which you gave to them was slightly on the higher side. And if the patients are not experiencing any of these, that means their dose is adequate. It's as simple as that. So buprenorphine usually doesn't have any kind of fixed dose. We need to titrate the dose clinically, looking at the requirements and the symptoms expressed by our patients. So the same thing which I was explaining to you, it has been shown here in the form of a flow chart. I'm not going to repeat it, but when you are reviewing it, probably this kind of flow charts would be useful. So on the second day, you again evaluate their response to the first day's dose and decrease your dose accordingly. And then by usually 3 or 4 days, most patients you will find have achieved their usual daily dose, the dose on which they are likely to be maintained. Usually this process takes about 3 or 4 days. In many cases, this may last up to 1 week also. Because sometimes it's difficult to determine whether patients are really abstinent or not, whether they are really comfortable or not. And only when you have their full trust, they will sort of report it to you whether this dose is enough for them or not. What we need to understand in this entire process is, it's very important to develop a kind of trust between the doctor and patient, that doctor is going to prescribe the adequate dose which is required by the patient. attitude of doctor need not be that back the dose, or person who is always suspecting the patient of over-reporting their symptoms. People or doctors who is suspecting the patient of just sort of asking for higher dose of buprenorphine for the purpose of intoxication. Buprenorphine sublingual is not really a very highly reinforcing compound, particularly by patients who are already tolerant to short-acting illegal opioids like heroin or injecting pharmaceuticals. So those patients, please do not think that they are obtaining our sublingual buprenorphine only for the purpose of intoxication. If they are asking for more dose, it's most likely for their comfort, for their maximum level of productivity. By and large, most patients are stabilized by 7 days. Again, the same thing explained here in the way of a flow chart. What are the reasons for which we need to consider an increase in dose? One is, if a patient reports to us, doctor, your dose is fine for me for the daytime, but by the time the evening comes, I again start experiencing withdrawal symptoms. Clearly an indication that we need to increase our dose. Sometimes people also try to address this clinical situation by giving an extra dose of benzodiazepine at night. Benzodiazepine is okay in first few weeks only for treatment of insomnia. But for treatment of opioid withdrawals, we have, since we are already using opioid agonist, why not use adequate dose of our opioid agonist itself? Also, another indication of increase in dose is when patients tell you that the opioids which they were using earlier, they are still using them even though the dose may have slightly reduced. For instance, some patients will tell you that in the morning, I take your buprenorphine sublingual tablet, I'm fine by the evening, but in the evening, I again have to take one more dose of either heroin, or again, I again need to have one more dose of injections. That clearly tells you that you need to increase your dose of buprenorphine, which is not effectively blocking the effect of illicit opioids. Also, some patients will tell you, no doctor, I am not totally motivated. I have decided not to touch the opioids, illicit opioids anymore. I'm also not experiencing any withdrawal symptoms. However, I still continue to experience craving. I still continue to experience desire. It's only my high motivation, my strong willpower, which is sort of stopping me from taking these injections again. What does this tell us? This tells us, one, that okay, your patient has good motivation, but this also tells you that your patient is experiencing a disabling and distressing symptom like craving. Craving by itself is quite a distressing symptom, even though it's subjective symptom, which deserves adequate treatment by the physicians, by the doctors. Just like we provide treatment for pain, similarly, we need to provide treatment for craving itself. So a person who has no withdrawal, who is not using opioids, still experiencing craving, should be treated by an adequately enhanced dose of agonist maintenance. These first three are easier to understand: withdrawals, opioid use, and craving. But fourth one is most important, and many clinicians fail to recognize the importance of the fourth factor. That is, failure to achieve a dose that blocks the euphoria of short-acting opioids. Sometimes what happens is, patients tell you that for first few weeks, patients tell you that, doctor, I was abstinent, I was totally clean by your dose, I was also very comfortable, I had no withdrawals, no craving, etc. Everything was fine. But yesterday evening, I met some of my old friends again, and I had to take one more injection with them since they pressurized me. And tell you what, doctor, that experience was really pleasurable for me. I really enjoyed taking that particular injection. What does this tell us? This tells us that your dose was not enough to block all the opioid receptors adequately. Some opioid receptors were weakened. There was still some room for illicit opioids to exert their effects. And our purpose in this treatment is to block the effect of these illicit opioids, which means this is again an indication to increase the dose of opioids. For these reasons, we need to increase the dose, and only then we can consider that we are treating our patients with adequate dose. How much dose is adequate for buprenorphine in India? Western data typically tells us is that 12 to 16 milligram is supposed to be the adequate dose. Maximum, some studies have even tried dose up to 32 milligram. Though it's not really of any added benefit, because beyond 16 or 18 milligram, buprenorphine starts exerting its ceiling effect, which means beyond 18 milligram or so, any extra doses of buprenorphine will not have any extra effects. In our experience in India, what we have seen is most patients would require dose up to 8 to 10 milligrams per day, though some may require even a higher dose and some may require slightly lower dose as well. There may be many reasons behind this. One of the reasons can be that our patients have different habit sizes as compared to the Western countries. The kind of opioids which they use, kind of heroin which they use is different. The kind of drugs which our patients use is different. There may be biological or genetic variations. And very interestingly, the Indian manufacturers of buprenorphine tablets, they claim that their bioavailability is much higher than the popular Western brands. So that may also be a reason why our 8 milligram is equal to their 10 or 12 milligram. Whatever the reason, we have found that in our country, 8 to 10 milligram is supposed to be the adequate dose for most of the patients, though the adequacy of the dose has to be decided on a case-by-case basis by the clinical criteria. I'll again stress this particular point, that even smaller doses may be adequate to control withdrawal symptoms of your patients. So let's say about 2 to 4 milligrams, your patients may say, doctor, I'm now fine, I don't have any withdrawals. But in order to control their craving, you need to go slightly up. If their withdrawal symptoms are being controlled at 4 to 6 milligrams, then for controlling their craving, they will require a dose of say 6 to 8 milligrams. And if they require about 8 milligrams to control their craving, that means to block the effects of heroin, they will require even higher. So that's how we can clinically judge if your patient is comfortable, just comfortable on 6 milligrams and reporting no withdrawals. That means for adequate control of craving, the patient may require up to 8 milligrams of buprenorphine. If he requires 8 milligrams to control craving, then approximately 10 milligrams or so would be required to suppress further use of heroin also. So this is a rough guide for us to titrate the dose as per the clinical needs of patients. All this was about induction. All this was about mainly for how we sort of prescribe the dose. Then we come to the issue of dispensing. We must all remember the plain buprenorphine is a kind of medication whose administration, as far as possible, should always be supervised, should always be a directly observed treatment, which means patient take this medicine under the supervision of healthcare professionals, and only then patient can go back and patient cannot carry it back home. At the time of dispensing also, though this is more of a standard operating procedure, that your dispensing staff, which means your nurse, must see who the patient is, confirm the records, obtain the proper signature, interact with the patient to determine whether they are currently intoxicated or not, and only after adequate record maintenance, this medicine should be dispensed. Why I am saying this? Because plain buprenorphine is also liable to be diverted and injected, and it does have much higher reinforcing properties than sublingual buprenorphine. So the buprenorphine, if someone takes it oral, which means takes it orally and it goes into the stomach and then gets absorbed, then a very small amount will be bioavailable. It will have virtually no action, and hence it is not a correct route of administration. If the patient decides to inject this tablet, since this tablet is dissolvable in water, sublingual buprenorphine tablets can be injected by patients by IV route. It will be absorbed fully. Patient will be very happy, though obviously this is not a very happy situation for the doctor. Doctors would not like the medicines to be misused this way. And hence, the ideal way of consuming buprenorphine tablet is sublingual only, where it exerts its agonist maintenance effects, and both the doctor and patient are happy with this clinical situation. So to minimize this risk, we do have something known as buprenorphine naloxone combination. When you mix buprenorphine with naloxone, which is naloxone, we all know, is an opioid antagonist. If you take it sublingually, about 60% of buprenorphine will be absorbed, will be bioavailable, but naloxone is not active by sublingual route, and hence sublingually you will perceive only the effect of buprenorphine. It will only be pleasure. However, if you be naughty and decide to inject this particular tablet, then both buprenorphine as well as naloxone will be absorbed, will be bioavailable. Naloxone, being an opioid antagonist, will prevent the reinforcing effect of buprenorphine, or may also even precipitate withdrawals, which will not be a pleasurable reinforcing effect for the patient, and hence the risk of diversion and injection will be minimized. And hence, if we are giving this medicine as take home, then buprenorphine naloxone combination is the only one which is preferred. As far as possible, the plain buprenorphine tablets should be provided only as directly observed treatment. Only in certain specific social or occupational situations, take-home medications can be indicated, but only in very certain circumstances, only with certain kinds of patients, and when all other due precautions are exercised by us. In fact, for these kind of profiles, where patients are continually using drugs, we don't know much about their psychosocial status, when they are only recently entered treatment, these are the situations where we should avoid any kind of take-home plain sublingual buprenorphine owing to its abuse and diversion potential. And now comes the issue of missed doses. It's very frequent that patients will not be very regular or punctual and hence may miss their doses. If the patients miss their dose only for one day, buprenorphine being a fairly long-acting drug, we don't need to worry much. We can just continue from the next day as usual. If the gap is much longer, 2, 3 or even more days, then we need to assess our patients once again and see whether they are using any other opioids in this period or not. What happens is, prolonged abstinence, patients lose their tolerance to opioids. So a typical situation is when patients go into jail. So someone who was on 10 milligram of sublingual buprenorphine finds himself in jail for about 2 months or so. After 2 months, he is released again. In the jail, if he was abstinent for these 2 months, did not take any opioids, that means he would have lost his tolerance for opioids. And now 10 milligram dose, first day itself, would be slightly on the higher side for him. He will experience some side effects, some sedation, etc. So that's something which we need to be careful about, that if patients have missed their doses, whether they are also lost their tolerance or not. If the patient tells you that they were using other opioids in between, that means they are still tolerant, and hence you are on a much safer ground to restart the same dose of buprenorphine. Also, if you are running a program of buprenorphine substitution treatment, you want most of your patients to be compliant and adherent to treatment. And hence, if the doses have been missed for the patients are contacted by your outreach, if you have them. If you have outreach workers or counselors or social workers who can make phone calls or home visits, then you can find out why is it that patients are missing their treatment. So this completes our most important phase of induction of treatment. This then comes the issue of maintaining this particular kind of treatment. In the maintenance phase, the most important aspect is now that you have achieved the patients need to take repeatedly their illicit opioids. Now they don't need to inject or take their expensive illegal opioids anymore. In this phase, the concentration should be much more on, number one, retaining patients in treatment, maintaining and complying and adherence of their treatment, and secondly, looking at their psychosocial functioning. Usually, what we have seen is that achieving an opioid-free lifestyle takes about first few weeks to few months of treatment. So let's say about 3-4 months you need to achieve illicit opioid free lifestyle. Thereafter, for achieving some kind of occupational stability, etc., you need about 6 to 9 months of time. You need to spend about 6 to 9 months on this treatment, where you start achieving some kind of occupational regularity, start earning some money, etc. But to fully regain the trust as well as the relationship in your family, in your neighborhood, in your communities, you require treatment for a very long period, often 1 to 1.5 years. So this is how usually the chart of recovery looks like. For initial few months, just achieve abstinence from illicit drugs. Then you start working and earning money, and then you start earning the respect, love, and affection of your near and dear ones. To achieve all that, and not just to achieve abstinence from illicit opioids. So in this phase of maintenance, we need to decide the frequency of follow-up with the doctors or counselors or social workers. Also an important point, the usual frequency which I usually suggest to people is that in first few weeks of treatment, it's a good idea to meet patients more frequently. For instance, every week or so in first month of treatment, and for first 3 months, every fortnight, and then when everything has been stabilized, once a month or so after their treatment is regular. But if the patients are, everything is fine, they are doing very well, even still, once a month or so, we need to see our patients and we need to renew our prescription. That means the prescriptions of buprenorphine which we are providing to patients are not indefinitely refillable. They are valid only for 1 month or so, and after 1 month, when we review their progress in treatment, only then we can renew their prescription for a further period of 1 month or so, only then they remain valid. Sometimes when doctors are prescribing this kind of treatment for 3 or 6 months at a stretch, that is the kind of situation which should be avoided. Also, the role of urine testing here. Urine testing, which means testing the urine for the presence of illicit opioids, is a very valuable clinical aid for making the decision whether patients are complying with treatment or not, and whether patients are abstinent or not. This just provides another corroborative, objective evidence of the progress of your treatment, of the effectiveness of your treatment. However, this particular kind of urine test for illicit opioids should never be used to penalize your patient. It should never be used, okay, your urine test is positive for heroin, that means you are telling a lie to me, that means you are still using heroin, that means this treatment is not working for you, I am not going to give this treatment anymore to you. That's not the approach we must take. Our approach should be, okay, you are still taking opioids, that means either our dose is not enough or the kind of psychosocial engagement we have with you is not adequate, and hence we need to work upon that. We need to see how we can improve our own treatment so that you achieve full abstinence. About other laboratory tests also, only when clinically indicated, we can go for other tests like liver function test or kidney function tests, etc. But otherwise, if there is nothing, no other special laboratory tests which are clinically mandatory to be conducted frequently along with buprenorphine substitution treatment. Also, important issue is here of co-prescription of sedative hypnotics. In the first few weeks of treatment, many patients would experience insomnia. Hence, it's not a bad idea to give them a prescription of therapeutic doses of benzodiazepines or any other sedative hypnotics. Say about 5 or 10 milligram or even 15 milligram of diazepam or nitrazepam to be taken at night. Very important aspect of this treatment is treatment adherence, and for this we need to assess our patients regularly. We need to incorporate the corroborative evidence, particularly by having frequent interactions with the family members or partners also. Also, we need to maintain adequately all the kinds of records for patients. At every follow-up, we need to see whether they are still using drugs, and drugs here doesn't mean only opioids. Many times patients substitute their opioid dependence with other kind of substances. So patients which are being treated for heroin dependence by buprenorphine will continue buprenorphine, but may start drinking very heavily, may start using cannabis very heavily. So we need to take into account other drugs as well. We need to ask about their any kind of discomfort, withdrawal symptoms and craving, any side effects of buprenorphine, any injecting or other kinds of risk behaviors they may be engaging in, and we need to take into account any improvement in their social or occupational areas, particularly their work, their earning, and their relationship with their immediate family members and neighborhoods. A very important aspect of this maintenance. Dr. Prabhat was mentioning some kinds of controversies about this kind of treatment which happened in Punjab. For many of such issues, if we have adequate records with us, we will be on much firmer ground to defend our treatment for authorities which are ill-informed about this kind of treatment. So we need to maintain all kinds of registers as well as clinical files for our patients, including the records of psychosocial sessions, counseling, the dispensing records, the proper signatures of patients, and so on. There are certain tips for taking sublingual buprenorphine. One is that whenever we give this tablet to people, we need to explain it to them that it takes about 3 to 7 minutes to dissolve. At this point in time, they should refrain from talking. They should also not be drinking or swallowing this tablet, because if it goes into your stomach, it's not absorbed and it's useless then. Also, it's important that you do not eat or drink anything immediately before or after taking this particular treatment. The international guidelines for buprenorphine suggest that tablets should not be crushed as far as possible. In India, however, usually these tablets are being administered after crushing them, because crushing at least ensures early dissolution and early absorption from sublingual mucosa. During maintenance phase, we need to ensure compliance. We need to keep providing them relapse prevention sessions and other kinds of psychosocial interventions, and keep involving their family members. Now, the important aspect of how long to continue this treatment. And many people really ask me, and they get worked up when I tell them that this treatment will continue for a very long time. Even many psychiatrists are uncomfortable in giving this treatment for a long-term basis for our patients. The same psychiatrists who get very angry with their patients of depression or schizophrenia, who stop their treatment early, they are very jittery when they are prescribing buprenorphine to their opioid dependent patients. This is simply because of many myths associated with this condition and this treatment. Just like illnesses like diabetes, hypertension, epilepsy, schizophrenia, depression require a very long-term treatment. Similarly, opioid dependence also requires a very long-term treatment. It varies from patient to patient. It may even continue for lifelong for some patients. In fact, the deciding criteria for adequacy of treatment is attainment of treatment goals, which means you need to achieve abstinence, you need to achieve good productive lifestyle, you need to achieve good relationships with your family, your neighborhood, your communities, you need to regain your lost respect in the society. When all this is achieved, only then you can decide about that now my treatment is enough, now I can gradually taper and stop my buprenorphine. How to stop this? In fact, doing this, you have facility and also. So like any other patient of opioid dependence, you can admit these patients and gradually taper their buprenorphine over a period of few days to few weeks in divided doses. But when you are doing it at home in ambulatory outpatient settings, then you need to go much more slower when you are titrating it to the lower level. What I have seen in many instances is when people are tapering their patients from opioid substitution therapy, let's say buprenorphine. So someone was maintained on 8 milligram of buprenorphine. Now you have decided that he's on buprenorphine for 2 years. Now he is doing well. Now I am ready to reduce and stop his medicine. You start tapering his dose, let's say 0.4 milligram every week. And by doing so, over a period of next 3 to 4 months, you bring the dose to something like 2.4 milligram per day. At 2.4 milligram, the patient tells you, doctor, any more reduction is not tolerable for me. Please continue me on 2.4 milligram. And then many times therapist also continues the treatment on this same reduced dose of say 2.4 milligram per day. What's happening here is you are now maintaining in effect the patient on a much lower dose of buprenorphine than what is required for him. Many of his opioid receptors are still there, which can be activated, on which other opioids can still act. So this is not a desirable situation. If you have decided that no, further tapering is not working for you, that means the decision to stop buprenorphine treatment is now being deferred for some other time in future. That means now you need to again increase the dose and bring the patient to the usual maintenance dose of 8 or 10 or whatever milligram he was upon. So that's an important point to consider, that either you reduce and taper it completely, or if it's not possible, then you again increase the dose and maintain the patient on the adequate optimum dose of buprenorphine, which means your maintenance phase will continue for some more time. If you are able to achieve complete stoppage of buprenorphine, then you can decide about naltrexone after buprenorphine. One alternative is that patients can go drug-free. Another is patients can go on antagonist naltrexone, which requires 3 opioid-free days before initiation. And once you start naltrexone, the Indian experience is not so bleak as reported by many of our Western studies. So Indian experience with naltrexone also is quite encouraging as opposed to the Western studies. There are certain things which we take into account. We're likely to make our programs much more client-friendly and much more successful for our patients. We must involve our patients as well as their family members, who are our primary stakeholders. We should bring about as much as possible flexibility into the entire processes of program. The medicine should never go out of stock, because if they go out of stock, then patients are forced to take illegal opioids once again, which brings another kind of ethical dilemma. And only in some very grossly antisocial situations you can stop someone's treatment on disciplinary ground. But as I was saying, more flexibility is always good for providing adequate kind of treatment to maximum number of patients. So that sorts of brings us to the concluding part of this talk today. I will just end with a few myths and their clarifications for this treatment. Many people continue to believe that your patients are still addicted. You have just stopped their heroin or injection Fortwin or whatever, but they are still addicts of buprenorphine. It's true that on our OST also, on our buprenorphine also, if the patients do not take their medicine for one day, they are likely to experience some discomfort and withdrawal symptoms. But that happens with many other medicines also. Hypertensives, if they are taking their antihypertensives on one day, they miss it, they will experience some discomfort. Anti-epileptics, if they do not take their medicines, they are likely to throw up a seizure again. People who are taking prophylaxis for migraine, if they miss their medicines, they will experience discomfort, they will experience headache. Similarly, patients on thyroid replacement, if they miss their altoxin dose, they are going to experience some discomfort. So experiencing a discomfort on missing your medicine is not just a sign of addiction, which means our patients should not be seen as addicts. They are just taking a long-term medication for a chronic, relapsing, non-communicable disease, just like diabetes or hypertension. Also, the term opioid substitution therapy is sometimes misinterpreted as you are just substituting one illegal drug with a legal drug. What we need to understand here is the term substitution here refers to the substitution which occurs in the receptor level in the brain. It's not substitution of one substance by another in patients' lives. It's substitution of one opioid with another opioid at the brain mu receptors, not substitution in your life with one drug with another drug. What's happening here is you are just giving a legal medicine in place of an illegal drug under full medical supervision with medical advice along with counseling. Many people also think this You just provide this medicine, pop this pill into people's mouth, and they'll be fine, which is also not true. Counseling, other psychosocial interventions, all of them form the complete package of treatment, and all of this is necessary to ensure adequate recovery for the patient. Also, we all know this is not really a cure. In fact, there is nothing called as cure for most of the medical illnesses. We all know that. We just help manage and control this kind of damage which is brought about by opioid dependence. Finally, these are some critical issues. If we select our patients appropriately, give them adequate dose for adequate duration, observe our procedures very properly, provide them adequate counseling, other interventions, and do a careful monitoring, then nothing can stop from our treatment from being successful. Thank you very much for your attention, ladies and gentlemen. I'll be happy to provide any clarifications.
Okay, I think thanks, yeah, thanks, Dr. Atul, for as usual excellent presentation. I think I just thought of sharing few information before I pass it to the audience. Last July, we did a similar program with, again, Dr. Atul was there, and the outcome of that was that one of the center in Raipur has started a Buprenorphine maintenance treatment facility, and then the patient were, so he used to come so far to here or Delhi or Mumbai. Now they take treatment there, and we obviously all of us assisted them to getting the records and some sort of consent form, and so that's the reason I want Atul to again come to us and motivate some more people to look at to help this group of people who are always difficult to manage. Any questions?
Absolutely.
Available perhaps. Dr. Atul, there's a question about what the available brands of buprenorphine in India are, and specifically about any availability or accessibility issues.
Yeah. Well, from this platform, it would not be improper for us to take names of any brands, but just between colleagues, for the knowledge of our colleagues, I'm sharing here. I'm not endorsing any particular brand here. I'm just sharing here. There are many companies now which have started marketing and manufacturing buprenorphine because of its rising popularity. The oldest company, till few years back, we had only one company which was manufacturing and supplying buprenorphine. The company was and is still called Rusan Pharmaceuticals. Their brand is known as Agonist for plain buprenorphine and Agonist N for buprenorphine naloxone combination. We also know that a very reputed company in the field of neuropsychiatry also came up with its own brand of buprenorphine naloxone and started marketing it to all of us. Started making it available in pharmacies also a few years back, but that was probably not observing the due procedures of drug controller general, hence it had to be withdrawn from pharmacies. But that company and some other companies are still providing buprenorphine naloxone combination to directly to either drug de-addiction centers or to some of the clinicians, to their clinics and their hospitals who can provide this kind of treatment to their patients. So a simple net search would also reveal presence of many companies and many brands. The good thing is, the good thing about this kind of competition is that the cost of treatment has really been brought down. From the procurement which is done by National AIDS Control Organization at the national level, it's done in very huge bulk, and that has brought down the cost of treatment considerably. Whenever I talk to my international friends, international colleagues, they always tell me that why in India you are using buprenorphine when it's so expensive, and not methadone, which is so cheap. When they are really surprised when I tell them the cost of buprenorphine in India, it's really cheap. It's much lower than the cost of methadone in some of the developed countries. I hope this is helpful. Yeah. Any other question?
I think
there's a question from Dr. Sabin, sir, who's asking why did psychiatrists get arrested in Guyana for giving buprenorphine?
Yeah. Okay, it's opening a Pandora's box, but let me give a very brief reply. The buprenorphine naloxone medication, which is available from the manufacturers, comes with a instruction that these medicines are to be supplied only either to the government's own de-addiction centers or hospitals with de-addiction facilities. Now this term, hospital with de-addiction facility, is quite loose and can be, I said rightly so, I would say rightly so, can be interpreted as clinicians who can stock this medicine and dispense it to their own patients. And that's what many of our psychiatric colleagues in private practice in Punjab, Haryana, Chandigarh had been doing. They were dispensing this medicine to their patients. And since Punjab has a very huge problem of opioid dependence, all of them had very huge number of clients with them. These two particular doctors who were arrested probably were arrested on the same charges of stocking this controlled medicine with them, and probably for not providing adequate records, etc., to the authorities. All the details of the case are not available. From the available information, all I can say is that authorities have acted in haste. The psychiatrist should not have been really arrested under NDPS Act. It's a legal argument, but I do not really think that NDPS provisions are applicable in this particular case. So that's what my opinion is, which is an opinion formed after consulting some of my lawyer friends. But again, we know the different lawyers have different ways of interpreting things, and hence judges may interpret things differently than we are interpreting them. But in nutshell, that was the case in Punjab.
Sir, there are two questions perhaps that we have time to take. One is a question from Dr. Indumati, who is
from Trivandrum.
Yeah, from Trivandrum, who is a little bit unclear as to starting buprenorphine alone or starting buprenorphine with naloxone, and about the dosage frequency and route.
Sublingual or oral?
Sublingual or oral?
Oh. I'm sorry if this was not made very clear. One thing is that there is no place for any oral dose of buprenorphine at all. Buprenorphine treatment has to be sublingual only. Start, finish, and between every time. Every dose has to be only sublingual. There is nothing called oral buprenorphine. Secondly, about plain buprenorphine or sublingual buprenorphine, that will be determined by the procedures which you are observing in your clinics or your center. If you are providing treatment only as directly observed treatment under your supervision every day patient coming to you, then plain buprenorphine is the way to go. If you are giving this treatment as take-home treatment, then the good idea is always to give them buprenorphine naloxone combination. In the initial phase, however, in the first 2 or 3 days, when we are undergoing the process of induction, it's always preferable, even if you are giving buprenorphine naloxone, you give them under your supervision only, because that's the time when you are determining the adequacy of the dose. So you don't want the situation in the first few days itself where patients can fiddle and play with their own doses. Once their dose is stabilized, then you can start giving them take-home sublingual buprenorphine naloxone. At our center, we always insist on first 2 months stabilization on plain daily buprenorphine dispensing. Only when patients are adequately stabilized on daily administration of plain buprenorphine, they are given take-home sublingual buprenorphine.
Sir, I have a question. I'm Dr. Anirudh. I'm senior resident here. Sir, as you have as you have excellently illustrated that this buprenorphine maintenance therapy is a collaborative approach. Now, many patients which we have in follow-up, they are doing well and they have been on this buprenorphine maintenance for some years as of now. Now, when we decrease or taper the medication, and they in general do well, subgroup. A few patients we have found that the last 0.4 mg or last 0.8 mg, they are not able to give way, and they are of the opinion that it should be continued for long. They say that we cannot do with this mild dose of buprenorphine. So what would be your take on that?
Yeah. A very good question. This is very commonly encountered in clinical practice, that once the decision to taper and stop buprenorphine has been made, and we start working on that kind of arrangement. But after some time, patients find that they are really not comfortable on reduced doses of buprenorphine, so they cannot even contemplate being totally opioid free then. And when that stage is reached, that means the decision which we made of making the patient substitution free is not really correct anymore. That means we need to go back on our decision, which means patients will need to be on maintenance treatment again. And in this phase, it's really not advisable to keep them maintained on such a low dose of buprenorphine. If the decision is, the clinical decision is, okay, you will receive agonist maintenance treatment, then the agonist maintenance treatment will have to be given on adequate dose itself. Compare it with, let's say, epilepsy. If your dose to control epilepsy is 300 milligram of phenytoin every day, and you decide to reduce and taper it, but you find that 25 milligram, beyond 25 milligram, you cannot reduce it. So that doesn't mean you will continue the patient with 25 milligram. 300 milligram is the adequate dose, we will give them 300 milligram to control it adequately. That's how for agonist maintenance also. If the decision is agonist maintenance, then the dose has to be optimum. If the decision is there to stop agonist maintenance, now we have achieved all that we wanted to achieve, then we work towards reducing and tapering it.
I think Dr. Atul will stop here because there are lots and lots of questions coming up. What I'm trying to do is that this software allows you to save all the charts. So I'm saving all the chart discussion and trying to probably formulate an answer and put it in the website. And also I'll take your help in case I find difficult to sort it out.
Sure. I'll be happy to in fact formulate or type some of the responses.
Yes.
And through email also.
Yes, sure. Yes. So yeah, that I'm doing. Second thing, probably couple of questions has come from different people. What should be the format of consent form and record maintenance? So last time what we did is that following the presentation, we actually, people who are interested to start a center, we sent them a prototype consent form and also send the record, one of the copy of the record which we personally maintain, mostly all of us maintain, and that has empowered them to start the center, and we also help them to connect some of the pharma companies. So I mean, probably online helps you to put things together and in a cost-effective way. That's how I did. And this time I have told all of the people, because there are a lot of requests in last two sessions about the guidelines, and most session this time we followed the IPS guideline. And in that context, I have actually talked with Dr. Basu, and he actually told me that he can give all the hard copies for the people who are interested. So I have linked the people who Dr. Gautam Saha will give the IPS hard copies to the people who are interested to get it further. Okay.
Great,
so this is how we are stuck here. And
in fact, for opioid dependence guidelines, which I was an author of, if people are okay with it, I can share my own soft copy of opioid dependence guidelines of IPS. The chapter which was written for IPS, I can share with you the PDF, and you can share with other parties also.
Dr. Atul, one question from my side. I was thinking for a long time, because normally we want to learning management system. Can I upload in our group? I mean, those who comes regularly, is it okay?
Come again, please.
This currently the people who participate in this virtual network, they have access to the like a Medscape style of learning management system. Okay.
Right.
So if you allow me, I can upload that in the learning management system, so they can access whenever they want your guideline. Is it okay?
Please go ahead.
Okay. That's fine. Then check with you.
Yes, sure. I'll be very happy.
Okay. I think thanks a lot to you, and in spite of busy schedule.
Thank you, everyone.
So I always display. Okay, so thanks a lot, and thanks from us from Nimans, and thanks to all